Friedreich's ataxia, short case presentation example for the RACP. Thank you for allowing me to examine this young gentleman. The examination findings showed a young man with significant ataxia, sensory deficits, and skeletal abnormalities suggestive of a progressive neurological disorder. With regard to the examination in more detail, the patient was alert and oriented. On general inspection, he was seated in a wheelchair with noticeable scoliosis and high arched feet with hammer toes. The speech had a scanning quality about it. The cranial nerve examination showed horizontal nystagmus on lateral gaze. Fundoscopy also showed early optic atrophy. The other cranial nerves were largely intact with no facial weakness, normal hearing, and appropriate palatal movement. On cerebellar testing, there was marked dysmetria with pass pointing on finger nose testing bilaterally. Rapidly alternating movements demonstrated significant dysdiadochokinesis, and a clear intention tremor was present. Heel to shin testing revealed prominent ataxia, and the patient was unable to maintain stable posture when seated unsupported. The sensory examination showed diminished vibration sense in the distal lower limbs and marked impairment of joint position sense in the toes. Romberg's sign was positive when the patient was briefly supported in standing position, suggestive of proprioceptive loss. Reflex examination showed areflexia in the lower limbs with absent ankle and knee jerks. The upper limb reflexes were reduced. The plantar responses were extensor in nature bilaterally, demonstrating positive Babinski signs. The cardiovascular examination, although limited, showed a displaced apex beat with a grade 2 to 3 systolic murmur out of 6, best heard on the left sternal edge, and an S4 gallop rhythm, which is suggestive of a hypertrophic cardiomyopathy. In conclusion, this patient presents with a collection of signs which includes ataxia, areflexia, extensor plantars, significant proprioceptive loss, skeletal deformities including pes cavus and scoliosis, nystagmus, and evidence of cardiomyopathy. These findings are suggestive of a diagnosis of Friedreich's ataxia. The differential diagnosis would include spinocerebellar ataxia, particularly those with early onset, vitamin E deficiency, ataxia with vitamin E deficiency, ataxia telangiectasia, and a beta-lipoproteinemia. To confirm the diagnosis, genetic testing for GAA trinucleotide repeat expansion of the FXN gene would be essential. Additional investigations that may be of benefit would be echocardiography, looking for features of cardiomyopathy, an electrocardiogram to evaluate for cardiac conduction abnormalities, a magnetic resonance imaging of the brain and spinal cord to assess for cerebellar atrophy and spinal cord thinning may be helpful. Glucose tolerance testing may also be warranted given the association with diabetes. An ophthalmological assessment for optic atrophy would be required. The management of this patient would involve a multidisciplinary approach focusing on cardiac monitoring, physical and occupational therapy, orthopedic management for scoliosis, and genetic counseling for family members.